Okay, everyone, I think that we're going to go ahead and start. I'd like to introduce Dr. Succar. He's a rheumatologist that practices in Oakland County, Michigan. He did his residency at Geisinger Medical Center and my fellowship in rhinology. Endoscopic skull-base surgery at Vanderbilt. He is the founding partner at ENT Care of Michigan, where he mainly practices rhinology and skull-base surgery. He operates out of Corwell, Royal Oak, Troy, and Trinity, Oakland, Ann Arbor. He is a partner with Dr. Asmaro in endoscopic pituitary surgery. He is passionate about improving patient outcomes while reducing their morbidity and believes that the endoscopic technique has provided this for many of its patients. This is evidenced by improved nasal health after surgery, reduced CSF leak rates, and improved smell and taste function after endoscopic pituitary surgery. He is a Metro Detroit native who loves the area, which I don't blame you, and is passionate about local sports teams and enjoys spending time with his wife and 2 children. I'd like to introduce him, and his talk is surgical pre and post sinonasal care.
Good afternoon. Thanks, Jill, for having us and putting together this great presentation or great talk or conference today. As you introduced, I'm Eric Succar. I'm a rhinologist in the area, and I've just started working with Dr. Asmaro on these cases. And my background is in rhinology and skull-base surgery, which is a subspecialty of ENT that focuses on sinus surgery and skull-base surgery as well. So we do a lot of surgery at the interface between the sinuses and the brain, and we do a lot of that through the nose. So today we're going to be talking about pituitary surgery in particular, and just kind of the pre and post-operative part. So everything before we get to the brain and then afterward. So kind of how we get there, how we try to keep it as functional as possible, and how we kind of improve outcomes using these techniques. And so it's a really cool field that's experienced a significant amount of advancement over the last few years. So we're going to kind of delve into that today. These are my disclosures, nothing relevant to our talk. So I think it's always important to start off a talk about surgery and things that we do, kind of going through the history of things. And I think in the future, when I give a talk, I'm going to give Dr. Asmaro's picture of what he saw in Italy with seeing something from before the window and zooming in versus getting past the window and being able to get the wide-angled view. Ironically, these scopes that we use, these endoscopes that we use, were actually developed in the 1950s and 1960s, and the endoscope that we use is something called a Hopkins rod. And so Harold Hopkins was a engineer, physicist in the 1950s, and he took what was the endoscope that was of that era, and he kind of advanced it. And what it was before the illumination, the way we got light from the front of the scope to the back of the scope was inefficient, and so you weren't able to get a really good view. It was really grainy, it was very inaccurate. And so what they did was they took all the gas out of this light chamber and they filled it with glass, and so that allows the light to really transilluminate to the tip of that scope, and that gives you this wide angled view. And so like everything good, it kind of started in Europe. So he started working with this company in Europe called Karl Storz in the 1960s. It's a German company that does most of the high-end visualizations and optics that we use nowadays. And they developed this Hopkins rod, and that's kind of like from that era up until now has really contributed significantly to a lot of different surgical fields, whether it's laparoscopic surgery or robotic surgery, and then endoscopic skull-based surgery. And so we went from that era into the 1980s and 1990s, where they started doing these surgeries in Europe. So they looked at mucociliary clearance for the sinuses, and they tried to find the natural openings to these sinuses and functionally open the sinuses. So patients who had sinus surgery actually were able to get a functional response, not just opening sinuses and cleaning them out of bacteria and things like that, but they also were able to regain their sinus function, and the outcomes were significantly better. So, after Harold Hopkins and Carl Storrs came David Kennedy and Heinz Steinberger. These were These were like the two forefathers of modern sinus surgery in the U.S. So these two individuals kind of helped bring this technology here. And then not only did they do that, they did a really good job of spreading the word of what this was. So we were able to start doing, very comprehensive sinus surgery through people's nostrils without external incisions. This kind of goes into what we were talking about earlier about, finding the right surgeon. So once this technology and these techniques started being adopted in the U.S., it actually, like anything, was met with some resistance in the field, and a lot of people were saying, no, this isn't the right way to do it. We should be doing it open. But truthfully, sinus surgery done open had a pretty significant morbidity and mortality. There was a very high rate of CSF leak, poor outcomes. The sinuses never really worked normally, but if you took the other technique, they actually started working normally after you did a complete surgery, and you could basically skeletonize the entire sinuses involving the orbits and the skull base and take everything up to those roots, and the sinuses would still work. So you could remove a lot of polyp disease and things like that. So really came a long way in a quick 10 to 20 year period. So shortly after that, neurosurgeons and ENTs and a couple key institutions got together and started saying, hey, well, they're exposing the entire skull base. Is it possible for us to use these endoscopes to do endoscopic sinus surgery? And so this is a really simplified explanation of kind of where we came from. But some of the first center where this really started happening was at UPMC. Amin Kassam and Carl Snyderman from neurosurgery and ENT got together and started utilizing these techniques. And this is a kind of more of the non-expanded view of the sella, but this was the view they got, and it's a lot different than the traditional view where you were either making a sublabial incision or going through the nostril and using a microscope. So at first, I think it was just nice because more people were able to get great visualization, and then as you've seen that as we've gone on, our outcomes are starting to trend in a different direction because we're utilizing that visualization to approach areas that were previously deemed unresectable. And then there are a lot more advancements besides this, but then in 2005, they described something called the nasoseptal flap or the Haddad flap. And this also made a big difference in what we do. This is when you do these surgeries, if you're trying to get a complete resection, you're going to be going up against the diaphragm of the sella, and a lot of times when you're trying to get the tumor out, you're going to end up with a brain fluid leak or a CSF leak, and in those cases, you need to be able to repair that area, and you have a lot of options in that scenario, and a lot of them are synthetic grafts or free grafts, but this graft in particular is really unique because it has a blood supply to it, and so you can see this earlier defect here being covered with this nasoseptal flap, and so that can open up a lot of options for you. But it also creates a lot of different considerations too, kind of long term. So kind of going from your history of how we got here to kind of where the ENT's role in this is kind of set up. It's always interesting because patients typically see the neurosurgeon first, and then they get referred to me for the secondary part of the consultation. And it's always like, well, what am I doing here? I'm in an ear, nose, and throat office, and it's always kind of an interesting conversation. I kind of have to explain it to them. I'm a big part of your care because I'm doing the approach and I'm doing the exit, but I'm also going to help you try to get as close to normal as possible when this is all said and done. And so preoperatively, it's really important to start with getting a great history from patients, and it really kind of dictates where you're going to be at in your care. So one of the most important things we kind of need to know is if you've had any previous nasal surgery. Those flaps that we were talking about get affected if you've had a septoplasty in the past, bad nasal fracture, things like that. We always ask about anticoagulation. We want to kind of know what kind of supplements you're taking, and we have to kind of get in touch with your cardiologist and come up with a plan, because it's different than just sinus surgery. You're actually probably going to be off your anticoagulation for some time after the surgery as well, if we can achieve that. And then lastly, and Dr. Gannon's going to be talking about this later, but it's really important, is you have sleep apnea. And in the acromegaly population, this is really common. The problem is that after the surgery, we're usually not going to reinstitute your CPAP right away. And so we want to know about it to begin with, and then we're also going to try to find ways to kind of help reduce the morbidity of not wearing your CPAP, because I've had to be there with a patient who has, severe fatigue from their sleep apnea and are, 3-4 weeks out from surgery and still haven't been able to start it yet. And so it's important to set expectations in this appointment about what to expect, what to think about. And a lot of times, we have to go through different ways to mitigate this, whether we're going to get a wedge pillow or elevate the head of the bed just to give some help during those few weeks, or I've had to put patients on nasal oxygen for a few weeks after surgery, which you can do, which is a lot less pressure on the repair and the skull base than a CPAP. So that's a lot of preoperative planning that's important. When you come in to see the ENT, there's a lot of anxiety over the nasal endoscopy, and it's sort of the first appointment with this, because every time you come in to see us again, we're going to be performing the nasal endoscopy. The first one's usually the worst because you haven't had surgery on your nose, or you may have had surgery and that's a little bit easier because it's more open. But even then, we try to mitigate that with proper anesthesia with the nasal sprays, and then also a lot of times I'll use a pediatric flexible scope for a first scope. And the nice thing is it's not like a regular laryngoscopy where we have to go all the way to the vocal cords. We're really only going to the nose. So I come in with a scope that maybe this long, but really we're only using the first few inches of the scope. So we try to make it as comfortable as possible for patients, but it is really important. It just helps us kind of get the lay of the land and have a good map of what we're planning to do when we go into surgery. The next thing that you want to do when you see the patient is just go through what imaging they have. In particular, from an ENT standpoint, we're a little bit more interested in the CT than we are the MRI, because the CT gives us the bony anatomy to the nose, and it kind of, sphenoid sinuses are really variable. So you could have a unilateral sphenoid where 90% of the sphenoid's on one side and there's the small parts on the other. There's an intersinus septum in the sphenoid that typically attaches to one of the carotid arteries. So we're the ones responsible for taking that septum down, so we want to kind of know where it is and how close it is. We have to look at the optic nerves and the carotid arteries, make sure that they're not dehiscent, which means that they don't have any bone on them, because if that's the case, we just have to be aware of it so that when we're operating in that area, we're just very careful. Also to make sure the cuts are right? So this is something that's really unique about sinus surgery, is that we use image guidance during these surgeries. So the MRI and the CT are actually fused and combined, and they're allowed to basically show us where we're at, the tip of our instrument is at, in comparison to those images. So not only do we have the video of where we're at, we also have the image guidance that's showing us where we're at. So again, when we talked at the beginning about the history, all this stuff has sort of happened in a compressed time frame. You're talking about the last 20 to 30 years that this technology has been developed and implemented and advanced pretty significantly. So at first it used to just be CTs that gave us guidance, and then there were only MRIs, and now we actually have a fused image of both the CT and the MRI, and we can play around with it in the OR when we're looking around corners or trying to maximize exposure. And then lastly, counseling, and this is a really important part too, because a lot of the sinonasal symptoms that you're going to have are things that you want to be aware of ahead of time and kind of know what to expect in surgery. what to expect after surgery, and how to kind of improve your long-term outcomes. So we start any surgical conversation by going over risks and benefits of the surgery. And every surgery, typically you'll say bleeding, infection, scarring is a pretty common risk. I think bleeding is not an insignificant risk from the surgery, like post-operatively, not intraoperatively. That's a different talk as well. But you could have a post-operative nosebleed. I think it's always important that patients sort of have a plan in place for what would happen if they were at home and they had a pretty significant nosebleed. Because the skull base is so exposed, you may not want to just end up at any ER. You definitely want to tell anybody that you see that you've had skull base surgery, just so that they're aware, they're a little bit more gentle about what they're doing to kind of stop any major bleeding. And honestly, if you can get to your operating facility, if that's feasible, that's an ideal scenario, because then they can get in touch with one of us, and then we would definitely know what was going on. And then we spend a lot of time talking about smell and taste function, because in skull-based surgery in particular, this can be significantly diminished. Now, it's definitely going to be diminished after surgery. And really, we don't know where your outcome is going to lay until about 3 to 6 months. So it's not uncommon for patients to have a reduced or diminished or even absent sense of smell and taste 3 to 6 months after surgery. But around that point, we start seeing that tends to improve, if it's going to improve. And a lot of the newer techniques that we've developed are aimed at really preserving smell and taste function. And that's kind of, one of the frontiers that we have as well. So we spend some time talking about that. And then we talk about what you should be doing after surgery. So the main thing is sinus precautions. We don't want you blowing your nose. When you sneeze, we want you to sneeze with your mouth open. So maybe that's something you want to practice ahead of time, because you really don't want to create pressure over the brain. And then the other thing you really want to be doing is you want to be planning to start doing nasal rinses and irrigations. I always start with just simple saline spray at first, and then by the first post-operative visit, I'll be switching you over to a nasal irrigation, typically just a Neomed bottle. But sometimes people like using things like Navage and things like that, which is an okay option as well. It's just whatever works. The neti pot's another one that people really like. But that's what's going to really help. When you have nasal surgery, there's nothing that's sutured together, right? So if you had knee surgery, they're going to suture your knee together. But when you have nasal surgery, it's basically creating a large raw cavity, okay? And in that raw cavity, everything needs to heal. And the way it heals is like if you skin your knee, right? You're going to develop a scab, and then that scab's going to fall off, and then you're going to re-scab until finally it remucosalizes and it forms a new barrier. And so when you do those rinses, you're at least allowing the scab to kind of come off naturally. Otherwise, they can stay a little bit longer. It just takes a little bit longer to heal. So you actually do a lot of my work for me, because I have to take a lot of those scabs out in the office once you come back to see me. And so having adequate nasal rinses is really important. So intraoperative considerations. Most of the operative stuff Dr. Asmaro already talked about, and I love surgical videos, but I was a little worried that it might be tough for everybody to see. But it seems like everybody enjoyed that part of it, so that was really cool. In order to do the endoscopic technique, a lot of people are using a septectomy in the back of the sinus. So part of the septum is removed during the surgery, and so we do this in a way that's aimed at really preserving your smell and taste. And so the smell and taste is, the fibers are typically in the top part of the septum, and then the superior turbinates as well. And so we try to preserve as much, if not all, of the superior turbinates, and then the top 1/3 to 2/3 of the septum in the back, even if we do the septectomy. And there's been a lot of data showing that's been associated with improved outcomes in smell and taste long term. We do as much as we can to kind of control bleeding intraoperatively, to make sure things are okay, and that we don't have any issues post-op. And then lastly, the CSF leak, and this does really impact how things are going to be post-operatively. So, we typically classify it into no leak, low flow, or high flow leak. And and they're all kind of addressed differently. So in most pituitary surgery, you won't actually have a CSF leak, and that's ultimately the goal, although it's not always achievable. And if that is the case, then really minimal nasal packing and repair of the skull base needs to happen. You can actually get away without really repairing the skull base, although most people who do it like to put at least a little bit of a synthetic layer in and potentially a mucosal layer in, just to kind of belt and suspenders the area. Sometimes the diaphragm's a little bit thinner than you'd think, and it just gives you a little bit of extra support in case there's a bad sneeze or bad nose blow that could kind of put a little extra pressure on it. But the nice thing is in that case is that you don't wake up with packing in your nose, and you can actually still breathe through the nose until kind of some of the swelling sets in, and then the crusting develops a few days later. But it's actually much more comfortable for patients. But in the case that there is a low flow or a moderate flow CSF leak, we would usually perform a multi-layer repair with a synthetic graft, a second overlay layer potentially, and then a nasal septal flap. So every once in a while you'll have a incision in the thigh and then the nasal septal flap as well, which tends to make the recovery just a little bit longer. And so when you're in those two different sides, there's just a little bit of a difference in how you want to approach the postoperative period. And we were going to talk about that in a second, but just the length of time that you want to follow sinus precautions and all those kinds of things. So when patients wake up from surgery, we want it to be as gentle of a wake up as possible. And that's really important with good communication between anesthesia and ENT. A lot of patients have sleep apnea that go into the surgery. So sleep apnea patients tend to wake up a little bit more difficult. They tend to require a little bit of positive pressure right when they wake up so that we can kind of maintain safety. And their goal is to keep the patient safe. And our goal is to, also do the same thing. But, the way that we do that is by doing a gentle wake up and a planned gentle wake up. There's a lot of different medications that we can do. So we want to avoid nasal cannula in the postoperative area and things like that. So we usually have a face tent instead of a nasal cannula. All patients spend the night after pituitary surgery, and there's potentially a couple of nights as well, depending on if we, have a CSF leak or if there's a couple other factors at play. So when you're in the hospital, you're going to have these little drip pads. This is a cool depiction of one. Sometimes it's just a piece of tape with a 4x4 underneath the nose. And that just helps kind of collect the drainage, right? You're not able to blow your nose. And so these drip pads are nice the first week to help kind of collect those drainage. And then you really want to follow those sinus precautions that we talked about. Oftentimes you'll be on a stool softener for a few days just so that you're not extra straining as well. If you can elevate your head of the bed a few degrees, even when you go home, that can be really helpful the first few nights. A lot of times you won't be having a CSF leak, you'll just be feeling all the blood products and all the mucosa kind of draining down the back of your throat. And so being a little elevated is really helpful. Plus, it also drains some of the pressure on the repairs and the skull base at that point while you're healing. And then sometimes you will have a lumbar drain in place depending on the severity of the leak. And if you do have a lumbar drain in place, then you won't be elevated 30 degrees, and you'll sort of be more on a first day or two, more of a bed rest type thing. You'll be able to get up to go to the bathroom, but they have to clamp the drain, so you're a little bit more confined the first few days. And then again, we want to avoid CPAP. So if you have severe sleep apnea, you're going to want to elevate the head of the bed and do like a nasal cannula oxygen. There's been a lot of debate about when the right time to reinstitute CPAP is. So there's really not a consensus on it yet, but I typically like to wait about 3 weeks and potentially about 4 to 6 if there is a significant repair that's required after surgery. After hospital care, so this is when you're going to come in and see your ENT again, usually a week after surgery. And the first visit, I try to be a little bit less aggressive with how much cleaning that we do. The goal is just to kind of get the bottom of the nose open, but it's just still a little soon to start going after kind of the sinuses themselves. And then I'll see you at 1 week and usually about 4 weeks post-operatively to kind of clean things out. And I always leave the caveat in there that if you're getting uncomfortable, you notice the crust is redeveloped, that's a good reason to just call in and just come on in, because a lot of times I can just take care of it in the office, and it's a pretty quick fix, and a lot of the discomfort will improve. And then after the first week, I usually start people on saline irrigations. This is my go-to saline irrigation, the Neomed sinus rinse. Again, there's the neti pot and the Navage are two other common ones. There's some other ones as well that are out there. The studies on these have shown that they're all pretty much equal. There's no major difference between them, except for the Neomed one's a little bit cheaper, and it's actually pretty effective. So I like it the most. I think most of my patients use that, although I've had a lot of patients switch to the Navage, maybe just due to advertising, but some of them swear by it. So I'm not the one to get in between them and things that they like to use. I mean, it's time intensive, right? So having to wash your nose out twice a day can be a lot of work. You want to use distilled water. This is really important. There's tap water has some potential for, it's like winning the lottery, but it's not the way you want to win the lottery because it has amoeba, and you can get an amoeba and it can be pretty devastating. So just use distilled water, replace the bottles pretty regularly. You can clean these bottles too in the microwave. There's some specific ways to clean it, but you're going to want to clean it about once a week at least, or maybe a couple times a week if you can. So it's a commitment, but fortunately for skull-based patients, it's not a lifelong commitment. It's a couple month commitment. If you have nasal polyps, it becomes sort of a lifelong commitment. So that's kind of important. And then again, another conversation about CPAP. It's something that we'll have a conversation about when to get restarted on it. Hopefully around 2 to 3 weeks, and then if needed, a little bit longer, depending on if you needed a repair. And then the most important stuff, long-term sinonasal outcomes. So there has been a reasonable amount of research on this. It actually kind of all got summarized in the international, this is our rhinology journal. It's a weird small subspecialty in the world of ENT, but we have a journal with a very high impact factor, so it's kind of nice. And we spend a lot of time looking at our outcomes and how to improve things. And skull-based surgery is a really big part of what we do. So we're really collaborative with our neurosurgical colleagues. So, we measured nasal outcomes with the SNOT-22 score. So a lot of times when you come to our office, we'll have you fill out these forms it's like a 22 questionnaire. And it's interesting because there's lots of different domains in this. So there's your breathing health, but then there's sleep health, and then your psychological health as well. And I think I'm really impressed with the conference is doing a lot of talk about, that side of things. And so your sinonasal health actually has a really big impact on your mood and all those things too. So we look at those we look at those outcomes pretty regularly. We're able to really kind of tease things out. The majority of what we've done research on in this particular field of smell and taste function afterwards, there has been a lot of papers out. The problem is they're very heterogeneous because they're looking more at all skull-based surgery, and so more anterior skull-based surgery is going to have a much different smell and taste outcome than pituitary surgery. But a lot of the newer literature with sparing the septal strip and preserving the superior turbinates and with some of the newer stuff that we're doing, the rates of smell and taste loss are getting down closer to around 10%. And so that's kind of a frontier that I think another area that we're trying to kind of improve on and continue to kind of get better outcomes for our patients. So that's really important. The other things that they haven't looked into much that would be kind of intuitive is what's happening with the septum. Does the perforation bother patients? And the truth is that septum in the back doesn't really cause the same symptoms as if you had a perforation in the front. And so most patients don't notice that at all. And we're not seeing an increased level of sinusitis in these patients. Once we get you through that first level of debridements in recovery, a lot of times the mucosa will normalize. So after the 3 to 6 months that we're seeing significant normalization of mucosa and things like that. But it's important if you notice something or if you're having continued nasal drainage, continued nasal obstruction, crusting, things like that, to get back into the ENT, because there could be, a little subtle change that might be pretty easy to fix from a sinus perspective, because we've got a lot of tools in our toolbox, and there just is a lot that we can do to kind of help the sinonasal health long term. So a small part of the surgical pie, but I think a pretty important part from the ENT side of things. So that concludes my talk right now. I just thank you guys again for having me, and I think we're going to do questions at the end. So thank you.